Hello, and thank you for joining us. My name is Sarah Fuchs, and I am a Community Education Specialist at MDA. We're thrilled to have you join us for today's webinar on caring for the caregiver. This learning event is a part of our larger MDA community education programs, which focuses on bringing the neuromuscular disease community together around education and resources. Be sure to visit the Community Education section on mda.org for updates on upcoming events. We are recording today's event and it will be posted online on our website for viewing on demand. Please know that all phone lines have been muted, but you can still ask questions. We'll have a Q&A session at the end of the webinar with today's presenters. Simply use the chat feature to type in your questions. Feel free to type in your questions and send them in as you think of them, and they'll be addressed at the end of the presentation. I would also like to thank our webinar supporter, Edgewise Therapeutics. We would not be able to provide community education webinars like this if not for their generous support. We are very thankful and appreciative. For over 70 years, MDA has led the way in accelerating research, advancing care, and advocating for the support of our families. MDA's mission is to empower people living with muscular dystrophy, ALS, and related neuromuscular diseases to live longer, more independent lives. Our mission comes to life through the 4 pillars of care, through our national network of MDA care centers across the U.S., we support individuals and families from day one of their journey. Champion, through our advocacy and education efforts, we empower families with information and resources. Catalyst, through our investments in research, we are furthering advancements in treatment discoveries. And community, through programs like Summer Camp, our Connections program, and our community events, we are helping individuals and families build supportive connections and relationships. If you haven't done so already, we invite you to join the MDA community by registering with us today. I am so excited to announce today's guests, Christina Trout and Kelly McCoy-Gross. Christina is a registered nurse who also acts as the Clinical Services Specialist at the University of Iowa Stead Family Children's Hospital. Kelly is a registered nurse who also acts as the Clinical Nurse Coordinator at Washington University in St. Louis and ALS Center and Miller Lab. We are thrilled to have you both here today, and now I will turn the time over to you.
It's been shown that chronic caregiving has a higher incidence of illness, such as high cholesterol, hypertension, depression. And so that's why we are helping you guys to find ways to better cope with things. You can go to the next one. So what type of caregiving help is available? So basically there's several different categories of help. So there's emotional health and physical health. Physical help, of course, would be household tasks, personal care, laundry, shopping, cooking, managing finances. And then there's the personal care of the patient themselves, such as bathing, dressing, administering medicines, tube feeds, transportation, things like that. But there's also emotional support to your loved ones with a neuromuscular condition, helping to minimize the patient's stress, environmental stressors. So lots of different types of caregivers. These can be family or friends that aren't paid, or they can be somebody through an agency, whether you use a loved one through an agency to help them get paid, or have an agency actually provide you to the help. And then the patient can also take a very active role in their care. So we're going to take a little bit of time later to discuss that in more detail. Next slide.
So our presentation is going to cover considerations for caregiving across a lot of different age groups. So bear with us as some of the slides may not fully apply to you, but hopefully you can gather information throughout the talk that's helpful. In pediatrics, we all kind of come into the world needing a caregiver. And as infants, our parents are typically the ones caring for us. But that is expected by parents to be a limited time. So if you have a child with a special health care need, the caregiving can be extended beyond what would normally be expected, including 24/7 care night and day. Um, we normally think of infants and children going to a babysitter or daycare once they get to a certain age, but there can be many fewer pediatric specialty services for daycare or babysitting for the infants and children who have special health care needs. Sometimes these caregiving needs extend beyond caregiving and really are medical or healthcare interventions in addition to the activities of daily living. When you're looking for someone to take care of your pediatric family member, you really have to take into consideration their social, cognitive, and their communication style and their motor development. Most daycares are set up to accommodate individuals with very typical development. And peers who are interacting may not understand physical disability or differences in cognition. However, this can be a really rewarding experience for other young children to learn about the needs of their friends who have physical differences. So we would hope that by integrating individuals with pediatric care needs into other daycare and care settings, that there would be a benefit to all of the participants. The trajectory of care in pediatrics tends to be hopeful and one of rehabilitation and maximizing future aspirations. This grows into an area of teenagers and care for the teen. Normally, parents are, again, expected to not be a great part of the teen's development once they're beyond those elementary school years. However, parents are often caring for an individual with Duchenne or perhaps SMA or other types of myopathy well into these teenage years. It can be physically and emotionally draining for the parents and for the teens that are experiencing this experience, they have a decelerated or a halted progression in their steps towards autonomy and independence. Normally, teens are ready to, go out on their own, hang out with their peers, and this can be a time of challenge for them if they have physical needs that prevent them from being autonomous. Parents can help to work through this by very early on in these pediatric years, allowing their children to hang out with their peers, facilitating their ability to get into their friends' homes, setting up opportunities for them to be with their peers without having parents around as they get older. During these teen years, for some types of medical conditions, there's actually an escalation of medical intervention and cares. This might be the addition of a BiPAP breathing support at night, or it could be that they go through a major scoliosis surgery where parent caregivers may not be sufficient to fully help them through that surgery once they're discharged to home. There are transition planning documents, usually addressing the ages of age 14 through 18. The MDA has a very nice transition guide, and there are access workshops and publications for neuromuscular disorders, helping families to identify what steps they might take during these pediatric and teen years to make the transition to adult caregiving more smooth. The transition from teenage years to college is one of those large transitions for caregiving. If individual needed caregiving at home through their pediatric and teen years, that's certainly going to continue into their college years. And this might be the first time that they're setting up a home away from home where they're hiring and managing caregiving that would have been done at home by the parents or family members. Again, a college setting is a little more supported. Oftentimes there's a meal plan and accessible housing so that the transition in caregiving is a more gradual one or more supported environment. For young adults, then, there's also a transition of caregiving that might include actually including a personal care attendant or a caregiver on their dates or hanging around with their peers or companions. And that's a big difference from having a parent around, certainly. But it's a new experience to be able to hire a personal care attendant so that you can maintain your connections with your peers and in the community. And then a lot of our talk will also talk about for adults who need caregiving, where you're balancing roles and relationships with your spouse, your children, and perhaps even extended family members, and the experience of the individual who's needing the caregiving, where they're dealing with the loss of control, which can be a source of stress and irritation and lead to family strife. And then finally, at the end of the talk, we'll talk a little bit about elderly, where the trajectory of care is more that of palliative or hospice care, where we're looking at quality of life over quantity of life. So I think we can go to the next slide. I want to touch briefly on caregiving at school, because when we think about those ages between even 4 for preschool all the way up through the age of 18, one of the first experiences that youth have with caregiving outside the family is oftentimes that at school. This is actually an excellent opportunity for youth to learn about self-advocacy, and these skills that they develop in telling others how to best care for them and their care preferences can be a great asset to have later in life when they are moving on to college or needing to have outside caregivers in the home to care for them. I would encourage families to have open discussions about disability, both in the home and at school. This allows a youth to grow up in an environment where they can explain to others what their needs are and not feel that it's a taboo topic that they can't bring up with others. There are a few resources for the very young children that are children's books. These can be found at a disabilities library, perhaps even at your local clinic or hospital. They can also be purchased online to read at home or use as a tool in the classroom for the teacher to work with the other students in opening discussions about disability and how best to care for your friends. For you as parents and your youth, you'll need to know who's on your team at school. Usually we recommend an established a 504 plan or an IEP team. And those planners at your school work with you, usually meeting twice or 3 times a year. It usually includes your school guidance counselor and the health office, usually a physical or occupational therapy, your teachers and support staff, as well as you and your child. It's very important that your child is participating in these meetings so that they learn how to self-advocate. They learn from what things you're asking of the school so that they know how to do those things on their own once they're without your help. Those meetings can address accessibility and accommodations, as well as if there's any healthcare interventions. It also is a time to learn flexibility. Some schools are very easy to work with, and others, this might be a learning experience for them too. And you're doing the job of teaching them how to best care for your child, but also for children that come through the school in the future. It's a time you can also troubleshoot and plan for things like field trips or how to access the campus later if you're going to college. It's important for you to be aware of policy or legal rights that may be relevant for caregiving at school. For example, I brought up whether or not you need something simple like accommodations and opening doors, getting your things in and out of a locker or a backpack. That's quite different than giving a G-tube feeding or doing tracheostomy cares. Some of those activities are going to be necessary to have a hired nurse, and usually it's the school's responsibility, particularly at a public school, to provide that one-on-one care assistance, whether that's caring for your basic needs and including using the restroom, washing your hands, setting up your cafeteria tray, or healthcare interventions. If you're unsure of your rights, you can contact the MDA National Resource Center. You may be introduced to legal aid services through your neuromuscular clinic, and you can ask for family navigators to be with you at those meetings or else to give you advice in between meetings. I think that covers some of my main topics on school. We can go to the next slide. Holly, are you muted?
Thank you. So I wanted to talk a little bit about accepting help and how to kind of ease into that. Oftentimes caregivers will start out doing all the care themselves, and as the patient's needs slowly increase over time, the the caregiver ends up taking on more and more and more tasks, and it can become very overwhelming. Often accepting help will start as informal assistance. So asking, a family member to pitch in, a neighbor, a friend, and it can be a rewarding experience to care for your loved one. It can bring you closer. It can make you feel important to each other, but it also can be very scary. So, a lot of times patients will get a new feeding tube or something along those lines, and their loved one will say, "Oh, I'll never be able to do this." And then within 2 or 3 months, they come in back to clinic and they're like, "This is great. It's so easy." So definitely can be scary to start out with, and hopefully with proper support can build your confidence. But it also can over time lead to loss of sleep, loss of personal time, loss of income is a big thing if somebody has to quit a job or cut back on hours to care for a loved one. And there are also a lot of new experiences for the patient. The loss of control is just a huge thing that we see people struggling with. The changing roles within the family, anxiety, fear of the unknown, and then oftentimes, as we know, communication difficulties can go with these types of illnesses, which can be extremely frustrating for the patients, as well as possibly some sort of cognitive impairment or dementia, which can sneak its way into and not be obvious until it gets to be a little bit more problematic. So next slide. So as far as informal assistance, ask for help. This is a slide, sorry, I'm trying to keep up on my other screen. So oftentimes the first things you'll do is you'll have a neighbor pop by and say, "What can I do to help you?" Be specific. My dietitian actually gave me this acronym, and I found it very helpful in a lot of areas in life. But so specifics is SMART, or specific, measurable, attainable, realistic, and timely. So, if your next door neighbor who loves to cook comes over, says, "Hey, we've got some doctor's appointments Tuesday. Can you please bring over dinner for Tuesday night?" If your Aunt Rita calls and says, "What can I do to help?" and she doesn't drive and she doesn't, have a great kitchen, you're not going to ask her for a meal, but you might ask her to, help with some other things that you can use. So somebody to come sit with a loved one during a doctor's appointment, make it very measurable. So like, I need you on Tuesday for 4 hours from this time to this time, or I need a meal for me and my hubby and the kids. And then timely, just be really specific about, I'll need this done by this time, or I'll need this on this time. Lots of examples of things neighbors can do: helping drive children around, housework, house repairs, yard work, pretty much anything that you no longer have time for, somebody else could be asked to help with. Next slide.
So Kelly talked about some of the things that you can be doing to accept help from family, friends, and neighbors. There are some additional opportunities to maximize independence for the person who has the neuromuscular disorder and improve efficiencies within your home. This is becoming an easier and easier task for people as smart home technology has been advancing. By purchasing and getting some of these things set up into your home, you can really help your loved one retain that control of their environment and independence. Some of the smart home technology can turn the lights on, turn the TV off and on by just using voice activated alerts. They can check who's at the door, they can lock the doors, open and shut the garage. There's really a wide range of things that you can do by having some of these features in your home.
And a lot of these things can be connected to an eye gaze device as well. So
good point. Right. I was thinking mostly voice activated, but you're right. Some of these things can be adapted in a variety of ways. And it's possible that you're not even sure how to really fully utilize some of these opportunities. So you should ask the experts. If you're attending one of the MDA clinics, usually there's OTs for occupational therapists, physical therapists, and assistive technology experts that can show you how those devices might be used to improve your home. And there are also instructional videos for training caregivers. If you search on YouTube videos and look up some of these things, you'll find a lot of different couples or families that are using these things already and that are happy to share their ideas that they've already established in their own homes. There are also additional equipment and devices that can make things easier for you and save time. Eventually, MDA will be publishing the new Caregiver Guide that has a lot of reference pages that giving ideas of where you can find more devices and more videos and expertise. If you are also wanting to just talk through some of these ideas, you can call the National Resource Center, and their experts can also talk through like question you might have about doing a chore around the house. The last way to improve independence and efficiency is to get organized. And I realize that takes time up front, but really we find that families need a master calendar with appointments and a schedule of who's providing caregiving each day of the week, each day of the month, each hour of the day. An online calendar can be shared with family and relatives or your hired help so that we're all on the same page about who's coming when and what their activities are going to be when they're there. To help minimize the amount of time it's taking you to update your extended family and friends, you could establish something like a Caring Bridge, which is a trademarked opportunity online to, after you have your medical appointments, you can put an update and share that information for anyone that you authorize to view that information. So those are some things that you can do even before you enlist outside help. Next slide. So now we're really talking about when is it that you think you might need extra caregiving. So we've up to this point really talked about initiating caregiving through family members, whether that be someone living in the home or extended family. But there are times when it's appropriate to add caregivers from outside the family, particularly if you're going through a chronic or very extended amount of time that caregiving might be needed. As I already talked about, this can increase efficiency in completing ADLs, that's the activities of daily living, and particularly for families that might be in a where there's a single parent caring for children or multiple children, or if it's just you and your spouse, one person may not be able to accomplish all of the caregiving needs, and two people can make that much more efficient and safe. So there are additional things like lifting and transferring or completing a bath that really you need two people there and it can't be done with just one person alone. The other thing that this allows is it gives the individual who has the neuromuscular condition more autonomy to do these things and to they prefer to get things done. And then you as the caregiver can actually leave the home or do other activities around the house if you've hired someone from outside. This gives you a break. We call it respite. And this is particularly needed when care escalates to be 24/7. The type of care that you need really is going to dictate what type of caregivers that you enlist from outside the home. And I think our next slides will address that.
Yeah, so basically, if you are considering a hired caregiver, there are several different levels of care, we call it. So there's home health nursing. So this would be something ordered by your doctor. I should have probably left the nurse out of there, but basically home health, your doctor can order, Medicare insurance covered home health. And that's going to be people that are licensed, whether licensed nurses, licensed physical therapists. And this is not going to be a round the clock care situation. These are going to be people who are going to come out to perform certain tasks, be in the home an hour or so, and teach you all how to sort of take over. So oftentimes, I keep coming back to the tube feeding, but it's a great example. If someone just comes home with a new tube feed, they're going to send a home health nurse out. That nurse will show family how to clean it, show family how to administer the feeding, troubleshoot any issues that come up. but they're only going to be in there for a few weeks at most, and then they're going to be leaving. Physical and occupational therapy as well can come in and educate caregivers and family members on how to do transfers safely, how to do a bath, how to do like what type of equipment might be helpful in the home, things like that. If you need more extended care, so someone there for like 4, 8, 24 hours a day, then you'll be looking at more of a hired caregiver situation. And that's not typically covered by insurance, but we're going to talk later about ways to kind of look at that. So even within a hired caregiver, there are different levels. So, this can be something as simple as hiring someone to come over and clean the house every other week so that the caregiver no longer has that on their plate. But then you can even get an aide that can help with personal care tasks for the person with the neuromuscular condition. And then there might be nursing assistants, LPNs, and then all the way up to RNs. Typically, that's going to depend on the patient's needs. So like somebody with a tracheostomy and a ventilator is going to require RN support versus someone who just needs a bath a couple days a week. That could maybe be done by a home health aide or an LPN. And so we're going to talk a little bit more later about kind of the cost differences and ways to sort of manage all that. Next slide, please. So the healthcare assistants, again, a lot of times family members can be taught most of these skills, even if it seems a little bit overwhelming at first. With education, family can definitely take over a lot of these chores. So personal care involves bathing, dressing, toileting, grooming. Of course, there's household tasks like laundry and cleaning, yard work. And then there's emotional care. So, your loved one with a neuromuscular condition doesn't want to feel like a patient. They still want to feel like a member of the family and like your loved one. So, spending meaningful time with them, conversation, taking time out to just be with that person. And then, there can be more, not necessarily personal care, but like hands-off type healthcare, like setting up medications, making, doctor's appointments, transportation. And then I guess I got a little bit ahead of myself on the last side, but we talked about the nursing duties and physical therapy already. This is going to vary. The level of care that you need is going to vary by different regulations that might be either set by your state, by your insurance company, or possibly by the agency, depending on how what they allow their employees to do. Next slide, please.
So what Kelly was describing was really kind of like a job description and thinking about what activities you think you might need to care for your family member or your spouse or friend. So once you've kind of thought through what it is that you think you need or that your doctor thinks that you need, it's important to then think through the job expectations for like, who do you want to hire? Who would you be comfortable with coming into your home? And really, you're thinking about someone who's capable to complete the job duties that you outlined or that you wrote a job description. But you also want to think about the characteristics of the individual coming in. Obviously, someone trustworthy. Oftentimes, we recommend a non-smoking caregiver. Since we prefer not to have smoke exposure, we want them to be on time, reliable, have good communication skills about when they're coming and when they might be leaving. Thinking about the hours of help that are needed. Is it during the day or is it during the night when you're sleeping and you would expect your caregiver to be awake during that time, or have a conversation about whether or not it's okay for them to sleep as long as they're waking up to alarms. The other thing you might think about is whether or not you have a preference for male or female caregivers. And while they're on the job, would they be allowed to use their telephones, take breaks, snacks, eat snacks, your snacks? Whose snacks? And again, whether or not you want them to remain alert during their entire time that you're hiring them to help. From the other perspective, the person you're hiring will have expectations of you as the employer. They want to know how you're going to reimburse them. Will you pay on time? Is this going to be done with a check or Venmo or some other means, or is it going to be through a third party? They also want to know who's the boss. So is it the person with the neuromuscular condition that's the boss, or is it a family member, spouse, or a trustee or someone else directing um, the care? They also want to know that if they are hired to be your caregiver, that you're going to stay true to the hours that you establish. Keep in mind that this is a source of income for people that are paid caregivers. And you want your home to be welcoming to someone that's coming in. And I realize this can feel like an invasion of your privacy, but they want to be, kind of an extended part of your family, perhaps when they're caring for your loved one as well. It's also important that your house is clean and that there's not obstacles for them to trip and move around if they're caring for your family member. So really a clear conversation about the expectations that you have for each other. And the next slide. So once you've thought about your job duties and the expectations, now you're down to finding caregiver help. And there's kind of two main pathways that you can take. You can either hire someone on your own to be a caregiver, or you can get a caregiver through an agency. Either way, there's going to be a process where someone is found, interviewed, hired, managed, paid. And really, there's also a consideration of doing a background check, making sure that there's liability insurance if necessary for some of those activities that are being completed, and that the person caring for your family member is competent if they're doing part of the cares. So you need to think about whether or not you as a family are comfortable doing these activities, or if you would rather have an agency provide all of that management and payment. I think when we talk about payment, it's really important to think of some of these details that we don't think about in our daily life unless you're an accountant, is that if you're paying cash or with check for caregiving, probably at the end of the year on your taxes, you're going to include that information as an expense. And oftentimes you'll have to provide the social security number of the person that you paid for those activities, those caregiving activities. That in turn means that then the income that they had requires taxation. And so you can get into stickiness if you're not clear about who's paying the taxes on the income for the person that's getting paid. There are also some sticky situations regarding flexibility about the care policy or guidelines or regulations. When you're working with an agency, typically they have some laws that they must adhere to, and the agency may have policy that's usually there for a safety reason. For example, that their caregivers cannot lift over 40 pounds, or that a certain licensure is required to give a medication, even if it's by mouth, that you cannot put that the caregiver cannot put a medication in the mouth if they're not licensed to do so when you're working with an agency. There's also some things to consider about who's managing the schedule and making sure that you have the 24/7 or 8 hours a day of coverage that you need. Is that something that you as a family are comfortable setting up? Or do you want to work with an agency? And then eventually, I think Kelly's going to talk about some of the pros and cons and who covers for persons when they're sick and not available to care for you. Next slide.
So anyway, we're going to talk a little bit about, first of all, about hiring somebody on your own. So a lot of times people decide to hire somebody on their own because somebody was recommended, a friend, a neighbor, my loved one is looking for work and they have experience in a nursing home, things like that. But you can also look for these people, ask on social media groups that you might be on for different neuromuscular conditions, classified ads, and then healthcare students often can be found through college employment job boards. They're a great resource for some part-time care or care during the summer or weekends. And then classroom aides for young children or students might be available as well. One thing to keep in mind is backup helpers. So if you're considering hiring somebody, you might want to consider hiring 2 people or having a person that's kind of on standby for backup. Oftentimes family will have one paid caregiver, and then if that person needs a vacation or is out, that can be a difficult situation for the rest of the family. And then if you are hiring a stranger that you don't know at all, especially nowadays, it's good to be really cautious with hiring safety. One of the good things that we have now available is Zoom or FaceTime. So when you first reach out to somebody about interviewing for a position, you're not going to want to give out your address, certainly. You might even possibly want to withhold your actual phone number and do an interview and a background check via video before you consider sharing those things with people. The last thing you want is for somebody to know your address and where you live, and that somebody who is possibly handicapped lives there, and then they turns out to be an untrustworthy person. And then during your interview, you would want to consider their first impressions. The MDA has ways to help you get background checks on people and just listen to your gut as well. So next slide, please.
So I'm going to talk then about the other pathway where you're hiring using an agency for your caregiving. Typically, when you're utilizing an agency for caregiving, it's done first by referral. A referral to a home health agency can be done by your primary care provider or your MDA clinic providers. You usually just need someone to make that referral and provide your insurance information. And once the agency gets the referral, they'll do what's called a benefits investigation, where the agency's billing people determine if your insurance or your Medicaid or Medicare is going to cover the costs of the agency care. Once it's determined that you do have that benefit through your insurance or other payers, the agency then conducts interviews and looks for someone to hire to perform your caregiving. Usually you'll have had an interview with them as well, with the agency, to think about, give them your job description and expectations, the hours that you need help, and put together a loose care plan about what your needs look like and who would best meet those needs. Your goal is to hire someone, who utilizes good care techniques that can get your job done for the least amount of money. And unfortunately, an agency typically pays on your side. Is the unfortunate part that they usually have to hire someone at a much higher cost than what you can do in hiring someone on your own. So your healthcare benefits may not go as far when you're working with an agency. So at any rate, once you've determined what your healthcare needs are and the agency has looked for and found someone to do the care, then they together establish a plan of care. This turns into an order that's sent to your doctor to sign. The doctor agrees to what the person coming into your home is doing. And then those are reviewed and updated and certified periodically. So it's a pretty formal document. I think we're ready for the next slide.
So just to review a little bit, this was a lot of information. So we wanted to give you kind of a quick pros and cons of each of these options. So, private hire, you might not have a backup for sick days, vacation days, things like that. Agencies should have someone available if someone calls out sick. And then there's, different interview processes involved. So with a private hire, you're going to do the interviewing of the caregiver that you're hiring. And then with an agency, the agency typically will come out to your house and they will interview you and your loved one. And, what kind of care do you need? And they'll help decide what level you need and what's the best fit for your loved one. As Christina said, it's likely going to be a little bit less expensive to hire a private hire. There can be more headaches, not necessarily always. It just kind of depends on who you get. And it almost certainly is more costly to go through an agency a lot of the time. With a private hire, you will likely get people that someone knows. So they would have come recommended, not always, but it can feel a little bit more trustworthy than an agency sending out strangers to your home. One thing I do like to note is I tell my patients this all the time. If the first caregiver they send from an agency is not a good fit for you for any reason, it doesn't have to be a good reason even. It's perfectly acceptable, and very, very oftentimes happens where you can call that agency, hey, so-and-so wasn't a good fit for my loved one, we'd like someone else. And that's definitely something that your agency will be completely familiar with and not think badly about. The agency will handle making any schedules, whereas if you have your own private hires, then you'll have to work out a schedule with them as well. Another thing I like to note is that, you know, when we talk about the levels of care, of course, the higher you go in a level of care, the more expensive it is. And as Christina mentioned, like some people might not, either by their agency or by state law, might not be able to put medications in your loved one's mouth. But there might be workarounds for these things. So don't necessarily let the agency say, oh, you need a nurse. Well, what can we do to maybe bring it down a level? You know, can we set their medications up in little cups with the times, and my loved one is able to pick that up and put it in their mouth as long as they're reminded? Or, you know, can we put all the tube feed in a bag for the day, and then all the agency person has to do is unroll the clamp? Like, so try to work, you know, think outside the box and work with the agency to maximize your money and where it's going. Next slide, please.
So we left off on the word money, and I do think that paying for caregivers is probably the biggest pitfall or stumbling block to getting caregiving, with the second being that there is just not enough caregivers in most communities, particularly if you need nursing care. So I think you should expect challenges in funding. And I would send you to your MDA care centers, social workers, and nurses to get some guidance on this. Typically, the payers include private pay, where you're paying out of pocket for caregiving. If your caregiving is necessary for you to get to a workplace or to maintain employment, often vocational rehabilitation or Department of Rehabilitative Services, whatever it's called in your state, might provide some of that funding because there is either an educational goal or a vocational goal. The most common way to pay for caregiving is through the Medicaid. That's your state-funded services. It's usually either Medicaid or Medicaid waivers. There's a lot of different examples state to state, but these are publicly funded services. And sometimes these can include paying a family member to be your caregiver. And in Iowa, we call that consumer-directed attendant care. And I put that there, consumer-directed attendant care, which is consumer-driven care, where you're allowed to hire your own caregivers and pay them out of a pot of money that comes from Medicaid. Now, there's a difference. Medicare is typically associated with senior citizens or persons with an older age or a physical disability. This is federally funded care, and this is typically only available on a very limited basis. So it's not a slam dunk that you would qualify for the funding through that source. Private insurance typically only pays for what we call skilled nursing. That's where an RN is required to do those activities. And I say they usually revolve around tubes. If you have a tube in your windpipe called a tracheostomy, if you have a tube to feed through your nose, like an NG or a G tube, if you have an IV catheter where you're getting infusions, those are most likely activities that are going to be done by a registered nurse and would qualify for private insurance coverage. Some people have long-term care insurance, and that depends on your policy coverage, whether or not you would get caregiving in the home. There are certain veterans programs where former service members might qualify for some caregiving through the VA benefits office. And there's a thing called the Older Americans Act, which I believe is administered through Medicaid, but I could be wrong about that. But it's also state-funded caregiving funding for persons who are over the age of 60 or age 65, depending on your state policy. Next slide. The training of caregivers is going to, at least in part, come from you or some training videos, whether you're working with an agency or if you've hired someone on your own. When you're hiring from an agency, usually they have the basic training, to be a nurse's assistant or a medical assistant or a nurse. But how you prefer to be transferred, how you prefer to be positioned during in bed, how you get your bath or your cares done, there's a lot of nuances to that that you might want to direct. So it can be helpful if you write out any specific instructions, if you provide a schedule of when these things and activities are to be done, and of course, what time medications are to be given, particularly if you are going to be away from the home and the caregiving is while you're away. I recommend that families make their own training videos for each activity. These can be kept on your phone or an iPad or your laptop so that you can share the training videos to any new caregivers that come to your home. You can share those in advance of them coming so that they have an idea of how the caregiving is to be done. You would probably want someone from your family that's used to giving these caregiving tasks, demonstrate how to do those at least for the first few times of a caregiver coming to the home. And again, you would want to have a master calendar describing what days that those individuals that you hire are away from your home and days that you might need extra help. Those are the days when somebody else stepping in tends to, cause a wrinkle that they don't know how to do your cares. And really it helps if you have these things written out and that your communication style is very clear and the expectations are known and that you feel safe with how things are being done for your loved one. Next slide.
So this is a really important slide, I think, and that's to talk about the patient's role. So especially as you probably know, I work primarily with adult patients. And it's very important that they still feel some control over their life, that they have an active role, that they're involved, that they're helpful to you. Often that, changing roles from being the caregiver themselves in the sense of, providing for the family, doing work around the house, and that change in role to being dependent on others can be very difficult for people. Of course, what the patient can do or what your loved one can do is going to vary depending on both their mental and physical abilities. But, if they would choose to, they can participate in the hiring process, interviewing caregivers, giving feedback, coming up with the plan of care. It's oftentimes patients are very, have ways they like to have things done. So that's why involving them when you're making those videos or making tutorials for caregivers is very important. But then also giving them roles to do outside of caregiving. So, a change in roles, like, my husband used to do the yard work and now he can't, but I used to pay the bills. Well, he can still use a computer. So now he's going to pay the bills and I'll do the yard work. So, just kind of swapping tasks for something that's a little bit more doable for the patient with a neuromuscular condition. And then, one of the really important roles of the patient is to acknowledge and accept help when their loved one needs help. Many people, this can be very difficult to let someone come in and give them a bath or, things like that. But, it's important to keep in mind that the primary caregiver, if they become injured or ill, that they're not going to be able to do their job. So they need to have that help and support in order to continue being the primary caregiver. Caregivers also need emotional support from their loved ones. And just expressing gratitude, spending time together when no care is needed are all very important. Next slide, please.
So we started our presentation talking about caring for the caregiver. And hopefully we've talked through some steps about how to go about getting caregiving from outside the home when needed. And I'm going to circle back to thinking about self-care and making sure that the caregivers that are in the home are caring for themselves, because ultimately most families find that those hours are covered from within the home a lot of the time. So really, we need to think about what is in the way of you caring for yourself as a caregiver. And oftentimes that's a practical issue that you feel like you don't have the time, you don't have the money, and you don't have the energy. And those may be valid barriers to caring for yourself, but we need to think through how you might get the help that you need. Other people tell us that they feel selfish, that their loved one is going through a difficult time and they feel that it's selfish to think of themselves. Kelly already addressed that you may not know how to ask for help and you don't know how to accept it. Or that you may feel like that you were given this task for a worthy reason and you want to show that you have the personal strength and stamina to do this all by yourself. But really, we would encourage you to take the steps to allow others to help you in this process. And we know that you're probably the best at caring for your loved one, and you have the feeling that no one else can do it as well as you. Um, with good teaching and good support, we can probably find someone to help you do these things. There's also the factor of stress, that stress can be a barrier to you caring for yourself. This situational stress or your negative perception of stress can impede how you cope with and adjust to the care needs for your loved one. Some of the factors that influence the level of stress in caregiving have to do with whether or not this is voluntary, or if this is something that you have to do. Caregiving can be very rewarding, but we know that there are different kinds of relationships, and this may not be what you chose for your spouse or for you yourself. And your relationship makes a difference. You may also have past experiences in caregiving or not have past experiences. And there are some types of caregiving that are particularly difficult, particularly if your loved one has a dementia or if they're physically demanding or have obsessive demanding type tendencies. And we would, again, encourage you to seek outside help because sometimes there are some solutions that can be looked at along the way.
Some strategies just for dealing with stress as a caregiver. There are a lot of things that you can control, and there are even more things that you can't control. So one thing you can control is possibly stepping away from a stressful situation. I know that oftentimes that loss of autonomy, loss of control can lead to some tension and bickering. So if you need to, and your loved one, of course, is in a safe place, step outside the room, put in headphones, listen to music, identify what you can and can't change. If there's anything that is within your control, even if it's something little, you can do things like take a walk, go sit outside in the garden and have your coffee, visit with a friend, even if you have a friend come over to the house and sit and have coffee with you in another room, and then break up. So tackle one thing at a time. So if if there's something really big ahead of you, that this isn't exactly a big task, but you have to give your loved one a bath and it's always a battle, deal with one thing at a time. First, I'm going to get the bucket of hot water ready. And now I'm going to, help them to undress, and just break things into smaller tasks are more manageable at chunks. And then we had already talked a little bit about in the slide about barriers to caring for oneself, how it can be difficult. Like you have to prove that only I can care for my loved one properly. But one thing I have kind of had to learn as a nurse, and that a lot of nurses have to learn, is that just because somebody does something differently than you do doesn't always mean it's wrong. So listen to your patient, your loved one with a neuromuscular condition, but have an open mind. If somebody does something a little bit differently, going back to my go-to example of tube feeding, there's 10 different ways to administer a tube feed. They all work. Some might work better for one person than another, but they're all going to get the job done. So, give up some of that control in order to let others help you. Taking time to do things for yourself, particularly exercise, it's going to help with your energy level, help with your sleep, reduce tension. So those are all good ways to help take care of yourself. Next slide.
I would like to endorse that most clinics will also over and over again recommend that you seek emotional support. And that might at first be that you're seeking the counsel of others, family and friends, asking them for advice or using them as a listening ear as you vent and talk through things. You may have family and friends, or even this, I see the chat room coming. To, you can ask others what they've done when they've gone through similar circumstances. Many times there are support groups that you can attend either online or in person, where others will give you advice about what they've done in similar circumstances. Usually they have a facilitator to guide sharing of ideas and suggestions. And then beyond support groups, seek counseling. Have a professional who knows about the emotional toll that you might be going through. Explore your emotions and how you're personally coping and adjusting to some of the changes that you've experienced in your home. This is a very safe place to talk, to vent, to cry, and sometimes just getting some of that tension off of your mind and off your chest can be helpful and allow you to take next steps, as well as really work through what are some options that you could do to help with your caregiving. Lastly, in that area is that sometimes difficulty with emotions and coping can lead to anxiety or depression, which are medical conditions. And those medical conditions can be successfully treated, at least in part, with medications. So if you're feeling blue, depressed, feeling hopeless, anxious, those are time to reach out either to your primary care doctor or to your neuromuscular community or your doctor so that you can be referred to someone who can give you professional support in dealing with your emotions. Next slide. Another area of support for emotions and just taking a break is called respite care. There's a lot of different terms that people have, either positive or negative connotations thinking about those terms, but respite is a formal term. It's defined as a short period of rest or relief from something that's difficult. So it doesn't mean it's impossible. It doesn't mean that you don't care for your loved one. Taking a break is sometimes necessary just because it's difficult. Respite care can be a short-term relief for primary caregivers that range from an afternoon for a few hours to several days or a weekend or even a week. Respite care can be provided at varied locations. Sometimes you have someone come into the home to provide respite. Other times there are camps that provide respite for weekends or weeks at a time. Of course, the MDA camp is an excellent opportunity for the youth between the ages of, I think it's 8 to 17 now. But many of those camps operate for adults as well, going through different avenues. And so it's an opportunity to, have fun for your person that has a neuromuscular condition as well as a time of respite. There are also group homes that are community-based that provide respite as well as adult care centers or facilities. Some of these options may have restrictions on whether or not the payer puts restrictions on whether or not the caregiver that's primary to the situation can work outside the home during those hours. So these are all things that you would need to explore, and often the social worker can help, or the camp or community center can help figure these things out with you. Next slide.
So kind of the last portion of our talk here is the role of hospice and caregiving. This is a passion of mine, hospice and palliative care. So I feel very strongly hospice is not just end-of-life care, it's in-home care, it's symptom management. A lot of home health agencies offer a palliative care service, so the patient doesn't necessarily have to be on hospice to take advantage of palliative care. Palliative care just means symptom management. So it's not curative care, it's symptom care. So caring for things like anxiety, nausea, shortness of breath, pain, all those things would be addressed. In order to qualify for hospice, there are certain criteria that have to be met. These criteria can vary widely based on insurance, your state, your different agencies, things like that. Typically with Medicare, patients have to have approximately a 6-month prognosis. It's very fluid. And generally you can order you can have hospice come out and do what's called an informational visit, and you get to interview them, but as well, they'll interview you and see if they qualify. This often needs a doctor's order, but not always. Sometimes you can just call and request an informational visit without a doctor's order. They likely will need a doctor's order to start care. So that's something to keep in mind, and stay in touch with your healthcare provider. If a person has Medicare, hospice services are typically covered under Medicare Part A. Even if you have a replacement policy like an Essence or something, it reverts to Medicare Part A, and there's often no copay for any of the services. They're provided by licensed medical professionals, so there are nurses, there are social workers. Oftentimes they'll have a bath aide. They have, sometimes we'll have therapies available depending on the agency or the state again. There's on call 24 hours a day. One of the big advantages is not having to call 911 or not having to go to the ER anymore. You can call and they will manage those symptoms right there in the home. So one of the things I often get asked is, when is it time to consider hospice? One of the things that I like to tell my patient is, if something were to happen, would your loved one want to be admitted to the hospital? Oftentimes patients reach a point where they say, I'm not going back to the hospital. And really then hospice is going to be your best option, because all of their symptoms can be managed right at home and they don't have to leave. So I want to address some of the kind of more common myths about hospice. If you can go to the next slide for me, please. So some of the myths are hospice is only for the last few days. They think people have to be within days or hours of death. Again, typically you need a doctor to state that you're likely to live 6 months or less. However, patients on hospice are re-examined and recertified every 3 to 6 months. And unless the condition improves, you're likely to be able to remain on. And as I like to tell people, getting kicked off hospice after 3 or 6 months is not the worst thing that could happen to you. Another myth is that they'll start morphine and just drug you up. Morphine is a great resource. It's wonderful for air hunger, people with breathing difficulties, shortness of breath, but they'll never force you to take anything. They'll educate and recommend things, but you have all the medications in the home. Your family and your loved ones administer all the medications, and so you will have control and the choice over whether or not you'd prefer to have a little something and maybe might get a little sleepy, or whether you would prefer to, deal with the symptoms and be more alert. And then talking about patients going into hospice and dying quickly. Actually, I've usually found this to be the opposite. So once you go on hospice, you lose that anxiety about having to get to doctor's appointments, having to have invasive tests, having to have, ER visits, call 911, things like that. So just that decrease in stress, the extra support, like the bath aides and the social worker and the chaplain, all that excess support can take quite a bit of stress off of family members and the patient with the neuromuscular condition. And I find that actually it seems that people live longer than they would have, and oftentimes, not always, but this can also often help improve your quality of life so much that it does not shorten your life. And then talking about hospice stopping all medications. So when you do your informational visit or initial visit, you can discuss your medication list. Often this is negotiable. They'll adjust medications on a case-by-case basis. And when they say you'll remain on things that keep you comfortable, this could include things like blood pressure medicine. Nobody wants their blood pressure to go sky high. You're not going to feel well. This can include things like antidepressants. Sometimes hospice agencies have what they call a formulary. So they might change out a medication to a formulary medication, but it should do the same thing. If it doesn't do the same thing, they should educate you on why they're making that change. And again, work with them and negotiate with them on those things that you're not comfortable with. I think that's it. We can go to the next slide. So
Want me to summarize? I was going to say, Kelly, you want to summarize? So I saw in the chat box coming up that MDA was commenting on many of their other additional resources. And one of the reasons we're giving this talk today is that the Caregiver Guide is being updated and due to be published soon. That resource, when you find it on their website, has many pages listing specific resources with links, phone numbers, and articles about caregiving. You can also call the National Resource Center and talk live with individuals that have a lot of experience in connecting families with the resources that they might need. We've both commented several times about the MDA clinic nurses and social workers, and I know in the chat there were several different resources and access webinars that you all may find helpful as well. So we hope that we've covered a wide range of ages and types of caregiving and reasons why it's important to support the caregivers. And I think at this point we're opening it up for questions, even though we know that we've started late and now ended a little late.
Thank you so much for that wonderful presentation. Yes, we will start questions. I know that some of you have submitted questions when you signed up for the webinar, so we do have those here. Let me just pull that up. All righty. So let's see here. We have the word burnout caught my eye. I am curious if you meant burnout from the caregiver themselves or burnout from the individual. So who should be worrying about burnout?
I was going to say my own. I feel that's an inflammatory word. We probably should have taken it out. Some people use the term caregiver fatigue. It's never burnout related to your relationship with the person that you're caring for. It has really to do with your energy level and your ability, especially with lack of sleep or lack of eating, to continually meet the needs of your loved one. And that you need to be nourished both emotionally and physically to maintain a high level of care for your family member. So, caregiving can be extremely rewarding. It is rewarding. So burnout really reflects being overwhelmed with the amount of caregiving sometimes and needing respite or relief.
Thank you. What are cost-effective options for lower income levels? Does the government provide coverage for seniors or spouses of veterans, which I know you briefly touched on?
Yeah, I did touch on that, and Kelly can comment too, since you do more adult populations. Elderly can apply for Medicaid. It's usually income or resource based, whether or not you qualify for Medicaid. And I do feel like Medicaid is one of the more common ways that you can qualify for funding for caregiving. And Kelly, do you want to talk about Medicare and VA or any of those?
Yeah, so typically I think the amount of funding available is going to vary a lot by your state. As you said, Medicaid, we do unfortunately find that a lot of people fall within this window of like they don't quite qualify for Medicaid, or they have Medicaid but they have a large spend down, which means you have to pay into Medicaid to be able to use it every month, and that can be range anywhere from a couple $100s a month to I've seen people with up to like $1,500 a month spend down. The VA, I can only really speak from a position of ALS, but typically the VA is very, very well. They treat their veterans very, very well when it comes to ALS. So I would strongly encourage any patients with ALS or a related neuromuscular condition to reach out to your VA and see if your condition qualifies for a service-connected disability. And then otherwise, I think it just kind of depends on your level of service. From what I've experienced in the past, like how long you served, what time you served in, whether you served in wartime, whether you were deployed, things like that. So that can vary the level of VA care.
Thank you. Where can you find support groups for caregivers?
So your MDA should have some support groups. Is that correct, Sarah?
Well, I was going to say our National Resource Center, which I believe the information should be in the chat. They can help you look up local resources in your area. We have a connections program. They can talk you through everything that MDA has to offer. If you know of anything, outside of that, feel free to mention it, but I would highly suggest connecting with a resource center specialist.
I think the concept of meeting in person for support groups has changed over the last 5 years with the pandemic in particular. I know here in the Midwest, we had trouble with support groups because, we can't have them during harvest time. We can't have them during planting time. So the concept of having virtual support groups has really lended itself well to getting people together and having ongoing relationships that you develop and see face to face, even if it's through a screen. Um, but you could also talk with your primary care doctors, your local people, because they may know of other support groups that support similar patient populations. So even though we're talking about caregiving related to neuromuscular disorders, there may be other support groups in your community that have similar support face-to-face in a meeting where you meet all together in person, if that's your preference.
There definitely seems to have been an explosion lately of virtual support groups, which is nice, especially if you have a relatively rare condition, which we know most neuromuscular conditions can be fairly rare. So there's a lot more opportunity to meet with people with similar conditions if you're able to do that virtually.
Yes, and I also saw that there was a question specifically about support group of peers with Becker muscular dystrophy. I think, I'm going to go back to my comment. MDA does have a peer-to-peer connection program. Again, you can get in touch with a resource center specialist and they'll connect you with that program. It's more of a one-to-one program, but I think that's something that is beneficial. So I would suggest that, and for any specific neuromuscular disease. I'm going to move on to another question here. So this one said, the school district told me they are not responsible to provide therapies for my daughter who has CMD. We homeschool and have a baby who has recently also diagnosed with CMD. We cannot leave the home right now to get therapy services for my daughter. Do you know any resources for in-home therapy services?
So in terms of resources for in-home therapy, it definitely varies state to state and community to community. Especially in smaller communities, there's often not a pediatric therapist available. I would say in regards to the first part, whether your school is required to do therapies. Schools are, if you're a public school, most public schools are required to provide what is necessary for access to education. So they're required to find a one-on-one attendant. And if you have medical needs during the school day, the school is typically required to pay for those. In regards to like physical therapy, oftentimes a school can decline paying for therapies that are not medically required during those 7 hours of school time. Now, I know that's not what parents want to hear, but that law can be interpreted a variety of different ways. I would encourage you, with your working with the school, to ask the school if they have what we call a family navigator. Ask if they have in different states, like in Iowa, it's called the Area Education Agency. In Illinois, it's called the Division of Specialized Care for Children. Usually there is state by state an organization of the state for educational purposes to provide you with the resources about your rights to have your child in the school and getting the care that they need as well as their education. I suspect MDA has some of those resources on their web pages as well. I think it's helpful if you team up with other families in your state so that you would be talking apples to apples and not apples to oranges about what resources are available. And then, sometimes it's getting creative if they're going to be homeschooled, working with teaching your personal care attendant how to do those therapies is perfectly acceptable as well. As long as you have a trained person training the person that's going to do the therapy, that usually works out okay. Hopefully that answered the question.
Yeah, thank you. So we'll probably take, I want to say, one or two more. We have a gentleman who is in his 30s, living with DMD, living at home with parents. He wants to know if you know of any assistive technology that he can use to dial 911 in case of an emergencies, because he's unable to use his hands to pick up a phone or smartphone.
I actually think that with the new update to the iPhones, that's an option that you do not have to press a button, that you can say Siri and then, dial 911. If you get an Alexa or the Google, Docs, I think it's the Alexa, you certainly should be able to do a voice activated request.
I'm not
Um,
sure that Alexa can call 911. I think that might be the problem, unless that's recently changed.
we would probably need to enlist our AT, assistive technology experts. Um, I certainly know of a lot of, tools that people can use to alert the emergency providers about your diagnosis and, using a medical alert bracelet, or I know some of the other organizations have, for Duchenne, have a medical alert bracelet that gives information about your medical condition and the care guidelines for Duchenne. Um, I would recommend reaching out to an assistive technology specialist. Some of the durable medical equipment companies hire those individuals. Your clinic should have access to the experts in that area. Kind of going back to the OT and AT people, I think would be a good place to start.
All right, well, thank you so much. Just because, as you mentioned, we are running short on time, I am just going to wrap it up for today. I would again like to thank our webinar supporter, Edgewise Therapeutics. We are thankful for their generous support as it allows us to provide community education webinars like this. If you're new to MDA and you have been diagnosed with a neuromuscular disease under MDA's umbrella, or if you or a loved one of someone who is diagnosed, we encourage that you stay engaged with us at MDA. You can do this by visiting mda.org/join and completing a short form. Joining is free and will keep you up to date on the latest research, educational programs, and supports. We would love to hear your comments about this webinar. Once you leave the webinar, a web page will automatically pop up with a short survey about today's webinar. Completing this survey will provide us with important insight as we plan for future educational programs. If anyone has questions after this webinar, please feel free to email them to mdaengage@mdausa.org, and we will follow up with you. So this concludes today's webinar. I want to thank our presenters again for all this great advice, and we hope to see everyone soon.